catheter. Remove the vacutainer. Clean the injection port with alcohol, unclamp the catheter, and flush it according to your facility's policy. Then reclamp the catheter, remove the flush syringe, and restart or reconnect any infusions as needed. Label all specimen tubes. Finally, dispose of any sharps in the appropriate container. If your patient has a PICC line, don't use a vacutainer device to collect a blood sample. Instead, withdraw each specimen using a 10 milliliter syringe. Make sure to flush the catheter afterward. All central venous devices have a risk of complications. Some occur during insertion and removal, others during therapy. When caring for a patient who's receiving central IV therapy, you need to be able to spot complications and respond to them correctly. Some of the most important complications include air embolism, pneumothorax, hemothorax, cardiac tamponade, venous thrombosis, infection, catheter dislodgement, infiltration, and catheter fracture. An air embolism can occur during insertion or removal of any central venous access device. It can also occur if the injection cap or administration set is accidentally disconnected from the catheter, if air isn't fully removed from the administration set, if the catheter is dislodged, if the catheter is torn, or if the hub is cracked. A patient who has an air embolism may complain of chest pain and shortness of breath. You may also note cyanosis, hypotension, disorientation, and a weak, rapid pulse. If you think your patient has an air embolism, clamp the catheter to keep more air from entering. Then turn the patient onto his left side with his head down. This position encourages air to enter the right atrium and will minimize migration of the embolus. Then notify the patient's doctor and give oxygen as ordered. One of another pair of complications, pneumothorax and hemothorax, may occur during insertion of a non-tunneled or a tunneled catheter. If the patient has one or the other of these complications, he may complain of chest pain, dyspnea, shoulder or neck pain, irritability, palpitations, or lightheadedness. You also may note cyanosis, hypotension, and unequal breath sounds. If you suspect one of these problems, notify the patient's doctor, remove the catheter if you're trained to do so, or assist with removal of the catheter, give oxygen, and prepare for and assist with chest tube insertion. Another complication, cardiac tamponade, may result from perforation of the heart wall. Signs and symptoms of cardiac tamponade include hypotension, pulsus paradoxus, jugular venous distension, narrowed pulse pressure, muffled heart sounds, diaphoresis, and dyspnea. If you suspect cardiac tamponade, notify the patient's doctor, give oxygen, monitor the patient continuously, and prepare for emergency surgery if needed. Any central venous access device can become occluded as a result of venous thrombosis. Certain risk factors increase the likelihood that thrombosis will develop, including cancer, sickle cell anemia, and previous pulmonary emboli, or deep vein thrombosis. Signs of venous thrombosis include sluggish flow, resistance when flushing the catheter, and edema in an area distal to the clot. The patient may complain of jaw, shoulder, chest, or ear pain. If thrombosis occurs, stop the infusion, notify the patient's doctor immediately, give anticoagulants as ordered. If the clot is in the lumen of the catheter, you may need to instill a thrombolytic to dissolve it. Follow your facility's policy. Infection is another possible complication of any central venous access device. Usually it relates to aseptic technique, the length of time a catheter or VAP is in place, the number of times the catheter or VAP is accessed, or the process of routine care. Infection is characterized by pain, redness, or drainage at the insertion site. The patient may also have a fever, chills, hypotension, nausea, vomiting, or a headache. If you think your patient has an infection, notify the patient's doctor, obtain blood cultures if needed, start antibiotic treatment as ordered. If the catheter or VAP is the source of the infection, remove it or assist with removal. Anticipate that the catheter may be cultured. And continue to monitor the patient. A PICC line, non-tunneled catheter, or tunneled catheter can be dislodged by vigorous flushing or excessive vomiting or coughing. An X-ray can tell you if the catheter is dislodged. Obtain an X-ray if you can't get a blood return, the patient complains of pain during flushing or infusion, or the length of the external tubing has changed. If the catheter tip of a VAP becomes displaced, you may note difficulty with infusion, movement of the VAP when you try to access it with a non-coring needle, leakage at the site, or a burning sensation in the area. An X-ray can confirm the position of the catheter tip. If a PICC line, a non-tunneled catheter, or a tunneled catheter becomes dislodged, or if a VAP becomes displaced, fluids or medication may infiltrate into the tissue. If the patient is receiving a vesicant medication, this problem is called extravasation, and it may lead to tissue sloughing. Follow your facility's policy to treat this complication. In some cases, you may need to administer an antidote. Catheter fracture is a complication specific to PICC lines. It usually results from using too much pressure when flushing the catheter, flushing with a syringe smaller than 10 milliliters, or using excessive force when removing the catheter. A patient with a fractured catheter may complain of burning, stinging, or a popping sensation in his arm. If you suspect a catheter fracture, place a tourniquet on the patient's upper arm near the axilla to keep the catheter from migrating. Notify the patient's doctor and assist with the removal of the PICC if needed. If you are specially trained to do so, you may remove a PICC line or non-tunneled catheter. Tunneled catheters and VAPs have to be removed by a doctor. Before removing a central venous catheter, especially a PICC line, it's important that you know the length of the catheter. After washing your hands, explain the procedure to the patient. Help the patient to a supine position, making sure the head of the bed is flat and his arm is at a 45 to 90 degree angle to his body. Place a linen saver pad under the patient's arm. Put on clean gloves. Carefully remove the old dressing. Pull the catheter slowly and gently until it's completely out of the vein. Place a sterile gauze pad on the site and apply pressure for 1 minute or until the bleeding stops. Then apply antiseptic ointment and a sterile gauze dressing over the site. Redress the site every 24 hours until it's epithelialized. Finally, inspect and measure the catheter to make sure you've removed it completely. If you meet resistance or suspect a catheter fracture at any time during the removal procedure, notify the patient's doctor immediately. The growing number of patients receiving central IV therapy makes your role in this therapy more vital than ever. By teaching the patient and his family about catheter insertion and maintenance, you can help prevent complications and keep the catheter in good condition. In your teaching, review the purpose of the therapy, the process of dressing and equipment changes, and evidence of possible complications.
But again, the home care company.
If the patient is receiving IV fluids or medications at home, you must also teach him and his family how to maintain the infusion and change the administration.